Welcome back to the deep dive. Today, we're really getting into gastroenteritis, that inflammation of the stomach and intestines. Pretty unpleasant for anyone going through it, and definitely something we need to nail for exams. You've sent us your revision notes, so think of this as your high-yield audio run-through. Our mission, basically, to unpack gastroenteritis definition, causes, right through to complications. We'll throw in some memory aids, some exam tips. Okay, let's dive in. What exactly is gastroenteritis?
So at its simplest, it's inflammation.
Yep.
Affects the stomach, affects the intestines. And what's interesting is how that simple definition covers, a whole range of bugs, viruses, bacteria, even parasites sometimes.
And the symptoms are pretty classic, right?
Yeah, the hallmarks are usually diarrhea, vomiting, maybe some abdominal pain. Sometimes a fever comes along with it. The good news, generally, is that with supportive care, mainly keeping hydrated, most people are back on their feet within about a week.
Okay, so let's talk about the culprits. What actually kicks this off? It's quite a varied list.
It really is.
On the viral side, there's Norovirus. Everyone knows that one. The winter vomiting outbreaks.
Very contagious.
Then Rotavirus. That's more the little kids, isn't it? Though the vaccines help there.
Absolutely. The vaccine has made a huge difference. And you've also got Adenovirus in the viral camp.
Right. And bacteria. What are the big names?
Well, you've got Salmonella, E. coli, and you need to remember E. coli 0157 specifically, because that one's linked to bloody diarrhea.
Okay, important distinction.
Then there's Campylobacter. That one's interesting because it has that association with Guillain-Barré syndrome later on.
Yeah, the neurological link.
And Shigella. Plus, sometimes it's not the bacteria itself, but toxins they produce, like from Staph.aureus, Bacillus, Clostridium.
Wow, okay. And the parasites?
Giardia, Cryptosporidium, and Entamoeba are the main ones to think about there. It's quite the rogues gallery.
Definitely. And how do these things actually spread?
Several ways. Contaminated food and water, that's a big one. But also person-to-person contact is really common. Think schools, nurseries, care homes.
Yeah.
And don't forget surfaces. Those bugs can hang around on door handles, taps, that sort of thing.
Great fomites. Okay, so with all those names, Norovirus, Rotavirus, Adenovirus, Salmonella, E. coli, Shigella, Giardia, Campylobacter, it's a lot. Maybe a mnemonic. How about no rotten apples, scare every Germy child? What do you think? Noro, Rota, Adeno, Salmonella, E. coli, Shigella, Giardia, Campylobacter. Bit silly.
Well, silly often sticks. If it helps you remember those key players, then it's definitely useful. Yeah. That's the goal, right? Making it stick for revision.
True. Okay, so who's more likely to get this? Risk factors.
Well, some are quite obvious. Poor hygiene, poor sanitation, they're major ones.
Makes sense.
Consuming contaminated food or water, clearly. Then there are factors related to the individual. A weakened immune system, maybe from HIV/AIDS or certain medications, that increases susceptibility.
Okay.
And interestingly, reduced stomach acid. If someone's on acid-suppressing drugs like PPIs, that natural acid barrier isn't as strong, so ingested bugs have an easier time.
Oh, that's a good point. And just basic food safety.
Yeah. Exactly. Improper food handling, undercooking things, especially poultry with Campylobacter, or not reheating food properly. Classic ways to get bacterial gastroenteritis.
And some groups are just more vulnerable, aren't they?
Definitely. Young children, older adults, and anyone with a compromised immune system, they tend to get hit harder if they do catch it. And if you think about it, connecting this to the bigger picture, a lot of these risk factors are things we can actually modify. Public health messages, individual awareness, it all helps.
So what actually happens inside the gut? The pathophysiology, once these bugs get in.
Right, so the pathogen, whatever it is, infects the lining of the GI tract.
Okay.
This causes inflammation, which damages the cells lining the stomach and the intestines.
And that leads to the symptoms.
Pretty much. The diarrhea happens because the inflammation messes with fluid balance. You get more fluid secreted into the gut and less absorbed out. Kind of a double hit.
Right. So leaky gut, essentially, and the pain.
The abdominal pain and cramps, that's largely down to the immune response kicking in, adding to the inflammation and causing muscle spasms.
And vomiting.
That can be triggered directly by irritation in the stomach, or sometimes the pathogen triggers signals to the brain's vomiting center. It's the body trying to expel the invader.
Sort of like your gut saying, get out.
Exactly. Think of it like a tiny army invading, causing chaos and disrupting the normal flow.
Yeah.
But it's important to remember the severity, how bad the symptoms are, and how long it lasts. That really varies. Depends on the specific bug, depends on the person's immune system.
Yeah, not all gastroenteritis is created equal.
Yeah.
Okay, now crucially, not all diarrhea and vomiting is gastroenteritis. We need to think about differential diagnoses.
Absolutely vital. There's a lot that can mimic it.
Like what? What's top of the list?
Classic food poisoning, often caused by bacterial toxins. The key there is usually the speed of onset really rapid, often just hours after eating the dodgy food.
Much quicker than typical viral incubation periods. Okay, what else?
Well, you've got your chronic conditions, like inflammatory bowel disease, Crohn's, ulcerative colitis. They cause inflammation too, but long-term, not an acute infection.
Right, different pattern.
Irritable bowel syndrome, IBS. That can cause diarrhea and pain, but it's a functional disorder. The underlying structure is okay. Viral hepatitis can cause nausea and vomiting, but you'd be looking for other signs like jaundice.
Yellow skin, eyes.
Appendicitis, the pain is usually much more localized,
Yeah.
often starting central, then moving to the right lower quadrant.
Okay.
UTIs, urinary tract infections, can sometimes cause nausea. Traveler's diarrhea, obviously relevant if there's a recent travel history.
Yep.
Even constipation, bizarrely. You can get overflow diarrhea around impacted stool.
Paradoxical diarrhea, right?
Gastritis may be linked to NSAIDs or alcohol. And in pregnancy, hyperemesis gravidarum or even preeclampsia could present with vomiting.
Wow.
And even rarer things like Addison's disease can sometimes have GI symptoms, so
Yeah,
you need to keep an open mind.
definitely. It really highlights why taking a good history is so important.
Exactly. Avoids jumping to conclusions.
So, quick question for you listening. A young adult comes in, sudden vomiting and diarrhea, started about 2 hours after a barbecue picnic. Compared to typical viral gastroenteritis, what's probably higher on your list?
Food poisoning, right? That rapid onset is the big clue.
Precisely. Okay, let's talk scale. How common is this stuff? Especially here in the UK.
Oh, it's very common. Particularly in winter, you see those norovirus peaks. It affects all ages, but like we said, tends to be more severe in the very young and the elderly.
And the numbers are big.
Huge. The notes mention something like 17 million cases a year in the UK. That's a lot of people feeling rough. Interestingly, bacterial causes tend to peak more in the summer. Things like Campylobacter, Salmonella, Staph.
Makes sense. Barbecues and all that.
Yeah, possibly. Viruses account for maybe 30–40% of cases overall in developed countries, but even higher in kids. Norovirus is the big one for adults, Adenovirus and Rotavirus for young children.
But the rotavirus vaccine has helped.
Massively reduce the burden of severe rotavirus disease in kids, a real public health success story.
That's good to hear. And globally, the main worry is...
Dehydration.
Yeah.
That's the killer, especially in severe cases that need hospitalization. In developing countries, sadly, gastroenteritis is still a leading cause of child mortality, often from nasty bacterial infections.
It's quite sobering, the sheer scale of it.
It really is. It just highlights how vital public health measures, sanitation, clean water, hygiene education, and personal hygiene are.
Okay, let's recap the clinical picture. What does it actually look like? We've mentioned the main symptoms is diarrhea, watery, or sometimes bloody.
Vomiting, abdominal pain, nausea.
Yeah, maybe a fever, loss of appetite, just feeling generally unwell. But the big thing to assess is dehydration.
Absolutely critical. The notes break it down nicely by severity.
Right, so mild dehydration. What are the signs? Maybe a bit of lassitude off their food, maybe nauseous, a bit lightheaded. Postural hypotension.
Exactly. Slight drop in BP when they stand up. For moderate, it gets more obvious. Apathy, tiredness, maybe dizziness, muscle cramps. You might see a dry tongue, sunken eyes, reduced skin turgor, pinch the skin, and it goes back slowly.
Yeah.
The postural hypotension might be more marked, but systolic BP usually stays above 90. Heart rate starts to climb, tachycardia. And they're not peeing as much oliguria.
And severe, that sounds scary.
It is. Profound apathy, really weak, maybe confused, or even comatose, clinically in shock. Tachycardia is usually marked. Peripherals might be shut down, cool, pale skin. Systolic BP drops below 90. And urine output is minimal or non-existent anuria. Recognizing these stages is key.
Definitely. And the history gives clues too, right? Like you said, outbreaks are just viruses.
Yet epidemics often point to rotavirus or norovirus, a winter vomiting bug. Bloody diarrhea, as we mentioned, makes you think bacterial, coli 0157, Shigella, Campylobacter, Entamoeba.
On fever.
Common in kids with almost any cause, but a high fever in an adult might push you more towards thinking about an invasive bacterial infection.
Got it. And basic assessment. Vitals, obviously.
Temp, BP, pulse, RASPs, standard stuff. And a quick abdominal exam, mainly to make sure you're not missing something surgical like appendicitis.
Right. For remembering those dehydration signs, maybe think mild. lethargic, anorexic, nauseous, lightheaded, postural drop, moderate, tired, dizzy, dry mouth eyes, skin pinch slow, systolic 90 but drops, tachycardia, oliguria, severe, apathetic weak confused, shocky, systolic 90, shut down peripherally, oliguria nuria, bit clunky maybe.
Whatever works, the mnemonics are personal, but breaking it down helps embed it. Now, investigations, key point. Most cases don't need any tests.
Diagnosis is mainly clinical.
Primarily, based on the history and symptoms, we don't routinely send off stool samples for every case of DMV.
So when do you send a stool sample?
Good question. The guidance suggests if the diarrhea is particularly painful, or if there's blood or mucus or pus in it, suggests inflammation or invasion.
Okay.
Also, if the patient is systemically unwell, high fever, very sick, or if they're immunocompromised.
Right, higher risk.
Recent antibiotics or PPI use, or a recent hospital stay makes you think about C. diff.
Ah, yes.
If you suspect food poisoning from the history, recent travel outside Western Europe, North America, Australian NZ might pick up less common bugs.
Okay.
Symptoms that are dragging on, say, over a week, definitely if over 2 weeks, if you're just not sure what's going on. Or if the person is in a high-risk occupation, food handler, healthcare worker, nursery worker, need to know for public health reasons.
Makes sense. And what tests do they do on the sample?
Usually culture for bacteria, maybe specific antigen tests for viruses like Rotavirus or Norovirus, or increasingly PCR panels that can detect a whole range of viral, bacterial, and parasitic DNA or RNA.
PCR is getting common now.
Very. And for patients who are quite unwell, blood tests are useful, FBC, UNEs, renal function and electrolytes, mainly to assess dehydration severity and check for complications like kidney injury.
And imaging, x-rays, scans.
Rarely needed unless you're worried about something else going on, like bowel obstruction or perforation, based on the clinical picture.
So it's a selective approach to testing.
Exactly. Focus investigations where the result will actually change management or is needed for public health.
Okay, management. The main principle is supportive care, right? Symptom relief.
Absolutely. And the absolute cornerstone is fluid and electrolyte replacement. Preventing or treating dehydration is priority number one.
Oral rehydration solutions, like diarrhoea.
Exactly. They're ideal if the patient can keep fluids down. Small, frequent sips. If they can't, or if dehydration is severe, then they'll need intravenous IV fluids.
What about meds for symptoms? Anti-sickness, anti-diarrhea.
Use antiemetics cautiously. They can sometimes help with vomiting to allow ORS intake. Antidiarrheals, like loperamide, are generally used with even more caution, or not at all, especially if you suspect an invasive bacterial cause, or C. diff, as they can sometimes worsen things or prolong illness.
Right, might keep the bugs in.
Potentially. And antibiotics.
Generally, no, unless you've confirmed a specific bacterial or parasitic cause that needs treating.
Precisely. Most gastroenteritis is viral and self-limiting. Antibiotics won't help and can cause side effects or resistance.
And preventing spread is key. Hand washing.
Crucial. Meticulous hand hygiene, especially after using the toilet and before handling food. Proper food handling, avoiding contact with others while infectious, all vital public health advice.
So in primary care, it's assess dehydration, advise on fluids.
Yes, assess hydration status first. Educate the patient and family on managing symptoms at home, especially fluid intake. Encourage regular small sips of clear fluids. Recommend ORS, especially for those at higher risk, the very young, the elderly, those with comorbidities.
How much ORS?
For mild dehydration, encourage small, frequent amounts. Reintroduce their normal diet gradually, as tolerated. Start with bland foods, perhaps.
And you mentioned generally avoid antidiarrheals, antiemetics, probiotics.
Not routinely recommended, no. Antibiotics only if a specific pathogen is confirmed and treatment is indicated, often after discussion with microbiology.
And advice on staying off work or school?
Standard advice is 48 hours clear of the last episode of diarrhea or vomiting. That covers most infectious causes, like norovirus. For some specific infections or certain jobs, longer exclusion periods might be needed. Always best to check local public health guidelines if unsure.
Okay. And when do patients need to seek urgent help? Red flags.
Definitely need clear safety netting. Telling them to seek urgent advice if they develop signs of severe dehydration, bloody diarrhea, severe abdominal pain, high fever, or if symptoms aren't improving or getting worse. Follow-up might be needed too.
And when would you think about sending someone into hospital?
Key reasons for admission would be severe vomiting preventing any oral intake, signs of sepsis, severe dehydration that needs IV fluids, if they're just not managing with ORS at home. Recent travel to certain areas might lower the threshold. Extremes of age babies, frail elderly, significant underlying health problems, or sometimes social reasons, like if they live alone and can't cope.
Got it. Prognosis, generally.
Generally good. Most people, as we said, recover fully within a week or so without specific treatment beyond supportive care.
But it can be more serious.
It can, especially in those vulnerable groups. Severity varies, complications can happen. Prompt management of dehydration is the key to a good outcome. Severe cases might need that hospital admission.
Okay, let's touch on those complications. What are the main worries?
Dehydration and electrolyte imbalance are top of the list. Losing lots of fluid and salts can really upset the body's balance, leading to metabolic problems.
And specific bugs can cause specific issues.
Yes.
Yeah.
Some infections can lead to systemic complications spreading beyond the gut. We mentioned hemolytic uremic syndrome, HUS kidney failure, low platelets, anemia linked particularly to E. coli 0157.
Nasty.
Very. Some bacterial infections like Salmonella, Shigella, Campylobacter yersinia can trigger reactive arthritis weeks later.
Joint pain, inflammation.
Systemic invasion of the infection is possible, but rare. Toxic megacolon is a very rare but life-threatening complication
Rare.
where the colon massively dilates, usually in severe colitis.
And the Guillain-Barré link?
Yes, with Campylobacter jejuni specifically. An autoimmune attack on the peripheral nerves causing weakness.
And other things. Malnutrition.
Possible, especially with prolonged or recurrent episodes, particularly in children in resource-poor settings. Intractable diarrhea can also occur sometimes.
So that list really drives home why it's important to take it seriously, even though it's common.
Absolutely. Especially in infants, the elderly, and the immunocompromised, the risk of these complications is significantly higher.
Right. So there we have it, gastroenteritis. Hopefully feeling a bit less daunting now, a bit more manageable for your revision. We've covered the definition, the causes, that long list. Risk factors, how it actually works in the body, what else it could be, how common it is, the symptoms, and especially dehydration signs.
When to investigate, the management principles, prognosis.
And those potential complications, hopefully that's a useful run-through of your notes. Do go back over them, maybe try some practice questions.
And just as a final thought, thinking about that global impact, especially on kids, what do you think are the most effective public health interventions we could push for worldwide to really cut down the burden of gastroenteritis? Something to mull over.
A really crucial question. And for more help with your MSRA prep, don't forget to check out pastthemsra.com and also freemsra.com. Thanks for joining us for this deep dive.